Good evening and welcome to tonight's Men's Health webinar. Tonight, we have the pleasure of hearing from not one, but two men's health specialists, Dr. Mark Kellerman and Dr. Ryan Dornbier of Urology Center of Iowa. They're going to talk to you about the signs, symptoms, and treatment options for erectile dysfunction and BPH. It's Men's Health Month, so in June, we celebrate men coming out, taking care of themselves, taking care of their health, and addressing conditions that are common like these. Throughout the presentation, we encourage you to ask questions if they arise. To do so, you're going to tap the screen of your mobile device or move the mouse on your laptop or desktop. You're going to see a toolbar pop up in Zoom. Find the one that says chat, click on that, type your question in, hit submit, and then we will address those questions at the conclusion of the event. So without further delay, I would like to introduce Dr. Mark Kellerman and Dr. Ryan Dornbier.
Hi, everybody. Thanks for coming today. We'll kind of get right to things, and I'm trying to click through, and there we go. So just some websites that a lot of the information that we're going to be discussing today is on these websites. So if you want to write them down or scan the QR code quick, please feel free to do that. So to kind of start off, I guess, Dr. Kellerman, if you want to do your introduction there.
Can you hear me?
Yeah.
Yep.
All right, good. I'm Dr. Mark Kellerman. I'm a practicing urologist here in Des Moines since about 2003 with the Urology Center of Iowa. With places I go include the Urology Center of Iowa office in Clive and at Broadlands Medical Center. Trained in Iowa and Nebraska, and I've been in Des Moines ever since, and have been treating erectile dysfunction and BPH as part of my practice.
And I'm Ryan Dornbier. I've been with UCI since September of 2021. Did my training in St. Louis and the Chicago area. I also did a fellowship in reconstructive urology and men's health, and so I've been happy to join the practice here in Des Moines. So without further ado, we'll jump right into erectile dysfunction. Erectile dysfunction, as many know, is the inability to achieve or maintain an erection for firm sexual intercourse. It's a very common condition affecting about 1 in 5 men 20 years of age or older, or about more than half of men over the age of 40. It affects approximately 39 million men in the United States, and those numbers are probably an underestimation for the most part. So the erectile process takes, I essentially say it takes two things. It takes blood inflow and blood trapping. So the arteries have to dilate to allow for increased blood flow, and then the veins need to collapse around that blood in order to maintain the blood within the penis to maintain an erection. So any disruption in that process can ultimately lead to erectile dysfunction. There are many ultimate causes and comorbidities associated with erectile dysfunction. Probably the most common is what we call vasculogenic erectile dysfunction, in which the arteries are clogged and therefore you can't get that blood inflow. It also can lead to stiffening of the veins, which can also lead to a blood trapping issue. Diabetes is very commonly associated with erectile dysfunction, as well as certain medications, neurological conditions, and endocrine conditions. So probably the biggest comorbidity associated with erectile dysfunction is diabetes. Many know that this is a very common condition and being increasingly diagnosed in the United States. 15.3 million men in the United States already have been diagnosed with diabetes. The reason it's important in terms of erectile dysfunction is it does cause that two-hit scenario in which you have decreased blood flow in, but also increased difficulty trapping the blood within the penis. Therefore, men are less responsive to oral treatments. Men tend to present earlier and with more severe erectile dysfunction when it's associated with diabetes. And sometimes erectile dysfunction can even be the presenting sign of diabetes. The biggest thing is that ED pills often require stimulation in order to result in the vasodilation needed for erectile function. And many men with diabetes have decreased neurologic input, which can also ultimately affect your responsiveness to oral medications for erectile dysfunction. Another big cause, about 40% of men with erectile dysfunction will have some form of vascular disease. Oftentimes, this is a pre-symptom to some sort of heart-related dysfunction, in that symptoms of heart disease are often preceded with erectile dysfunction by 2 to 3 years. And the reason that is when you think about it from a global perspective, you know that certain arteries in your body are bigger than others. So therefore, the penile artery is actually a little bit smaller than the main artery in the heart. And therefore, if those arteries start to narrow or start to clog, you're going to experience erectile dysfunction first, followed by potentially some sort of heart-related event, just due to the pure mechanics of a smaller artery. The biggest thing with both erectile dysfunction and with cardiovascular disease is risk reduction, and things that we can do to try to improve our overall health, including diet, exercise and physical activity, making sure you get that 30 minutes a day of cardiovascular exercise, weight loss, quit smoking if you're a smoker, control your blood sugars if you have diabetes, and do your best to reduce stress. Another big cause of erectile dysfunction is prostate cancer and the treatments associated with prostate cancer. Men who undergo a prostate removal or a prostatectomy for treatment of their prostate cancer can often damage the nerves associated with erectile function, which can lead to long-term erectile dysfunction even after you've healed from surgery. In addition, many men are treated with radiation therapy for prostate cancer. And so when you look at surgery and radiation kind of combined, somewhere between 25 and 75% of men, which is a wide range, are going to experience some degree of erectile dysfunction after treatment, and sometimes even years after treatment, and that goes for radiation as well. Some other conditions that are associated with erectile dysfunction: low testosterone. You do need endocrine input in order to function from an erectile standpoint. And so if you have low testosterone, sometimes you can have a decreased libido, which ultimately affects your overall erectile quality. Additionally, Peyronie's disease is a process which leads to scar tissue in the penis. A much more commonly diagnosed condition because it can lead to curvature along with erectile dysfunction, which can be very problematic, one, to maintain erections, but also if you have enough curvature, it can make intercourse difficult. So with all these various causes, I think everyone's most important of what can we do to treat erectile dysfunction. And there are a multitude of treatments, but the ones that are considered probably standard of therapy at this point would be medications, injections, the vacuum device, urethral suppositories, or the penile implant. So the oral medications have been around since the mid-90s and are probably the first option for most men. Basically, what they do is they increase the level of nitric oxide inside the penis, which allows for increased vasodilation. About 60% of all men who present with erectile dysfunction are going to be responsive to PDE5 inhibitors, but they have some fairly significant side effects, including visual changes, nasal congestion, heartburn, just a severe headache. And therefore, some men are excluded because they can't take PDE5 inhibitors along with nitrates for chest pain. And so often men will not enjoy the use of these medications due to the side effects. Another option is intracavernosal injections, which is where we teach you how to inject yourself with a medication. This was around before medications for erectile dysfunction, and therefore about 15 years beforehand, you give a small dose of medication directly into the penis. About 90% of all men who try this will have some sort of response. Side effects are usually penile pain. It's a little bit clumsy and awkward to try and inject yourself sometimes. The most common reason for discontinuation is just that it takes too much prep work to get the erection. Vacuum devices are a good option, especially with a ring for men with poor ability to sustain your erection. you basically put a vacuum pump around the penis, pull blood into the penis, and then put a ring around the base of the penis to maintain the erection. The biggest problem that most guys have with it is that they're sometimes difficult to use and also cause a lot of bruising. If you've ever put a rubber band around your finger and seen it turn, black and blue and red and stuff like that, it can be a little bit uncomfortable. Urethral suppositories, I'll just kind of briefly talk about these. They're not utilized a whole lot anymore, partly because the name brand one, the Muse there, I don't think is really available as much as it used to be. But you basically put a suppository into the urethra and then kind of rub it in to make the medication act locally. But it causes a lot of pain, it causes irritation with urination, and putting something in the tip of your penis for erections isn't always an enjoyable process. So the last one I'll talk about is what's called a penile prosthesis. So basically, this is a surgically implanted device in which the device rests entirely inside the body. It will give you an erection essentially 100% of the time, and it lasts for as long as you want until you hit a button to make the erection go back down. So basically, as you pump the device within the scrotum, the erection goes up, and when you're done using it, you hit the button, it goes back down. The biggest side effects are any sort of surgically related side effects, but once men are able to recover from surgery, they have a great experience with the device. So just to kind of show you how things work, there is an animation associated with it. So you can see as you reach down to pump up the device within the scrotum, you have transmission of saline from this area here down into the pump, which pushes it up into the device, which then leads to an erection. And when you're done using it, you hit that button, and then the reverse process happens so that fluid returns to that reservoir up by the bladder, and the erection goes back down. So basically what to expect from the procedure is it's an outpatient procedure done under general anesthesia in most cases. There's a small incision made to place the entire device through. When you wake up, sometimes you'll have a catheter, but more typically we're removing the catheter after you wake up and send you home the same day. I usually have you return a couple weeks later just so I can check on the incision and make sure everything's going okay, and then teach you how to activate the device sometime between 2 and 4 weeks after the operation. You can usually go back to your regular routine about 2 to 3 weeks after the surgery. And then by 4 to 6 weeks after the procedure, you're able to use the device for intercourse. So benefits, one, it increases spontaneity. You don't have to fumble around with pills. You don't have to figure out timing of pills or timing of injectable medications. And therefore, it has a very, very good satisfaction rate. Typically going to be covered by insurance. Medicare pays for it fully, and then pretty much every plan follows suit with that. It's basically a permanent fix to any erectile dysfunction because the durability of the device is very good, with 10-year durability of 90%. It's designed to maintain all natural appearances in both the erect and flaccid state, so no one's going to know if you have it in or you don't, and it does not interfere with ejaculation or orgasm in that regard. As a surgical procedure, there are always risks associated with this, and if you are interested, we go over these at length. But basically, bleeding, infection is probably the biggest risk. It's about a 1 to 2% risk of infection. Sometimes the device does require revisions because of mechanical issues related to the device. And then other things that guys complain about include potential changes to the shape of the penis, as well as potential pump-related issues, but all things that can be addressed in the future. So with that, ED is a very common condition. It's very treatable. Treatment options are always evolving, and one of those treatment options is what's the penile implant, which can offer long, lasting, and satisfactory solutions to erectile dysfunction. And with that, I think I'll turn it over to Dr. Kellerman so he can talk to everyone about BPH.
All right, thank you. All
I'm
right,
gonna give you control.
Oh yeah, sure, thanks.
I don't know that I can do that. I think Dr. Dornbier might be able to do that because he's sharing the screen.
I can give control.
I will take it.
Yeah. Well, I don't know how to do that, so I'm going to just click through for you.
All right, so we'll start by talking about the prostate itself. I often get the question, "What the heck is the prostate? Why do I need it?" The prostate is important during your period of your reproductive years. It has the role of kind of helping the sperm get to where it's going. But other than that, it's really important just because of anatomically what it's associated with, and that's the urethra, as well as the nerves that are involved in erectile dysfunction that Dr. Dornbier had mentioned. Generally speaking, in most men, it does grow as we get older, but it's at varying rates. So that some men start experiencing symptoms related to it earlier than others. Let's see, there we go. So there are a number of different disease processes in the prostate. Probably the most crucial one as far as effect on life expectancy would be prostate cancer, but probably the most common one as far as how it affects quality of life would be BPH, or benign prostatic hypertrophy, or hyperplasia. And also there's prostatitis, which causes an acute change in symptoms. If you have BPH, you can have an increased risk of prostatitis, but BPH does not increase your risk of prostate cancer. So it's kind of another slide just kind of showing in a diagram form, talking about BPH and what the acronym stands for. The most important part of the acronym, I think, is the B. This is benign disease. It does not become cancerous. The hyperplasia, or the prostatic, is the P, and then hyperplasia is more cells than normal. So that's where we come up with that acronym. Other common ones are BOO, which is bladder outlet obstruction, which can be for many reasons, one of them being BPH. And then we commonly use LUTS, or lower urinary tract symptoms, to describe what's going on. And I think I kind of touched on this a little bit earlier, but it does not cause cancer. It can cause your PSA to go up, which can cause you to have to visit a urologist, which may lead to a biopsy, but BPH itself does not progress to cancer. You can have both in your gland, but they are distinct disease processes. And this is a picture kind of showing normal versus enlarged. And the picture on the left, the urethra is kind of unimpeded. It's not being compressed by the gland, so urine flows easily through the urethra and then out through the penis. As the prostate gets larger, it starts to impinge on that urethra, and then your bladder has to start working harder to push that urine out, and it can compensate for a while, but eventually, if nothing is done and the disease progresses, the bladder cannot compensate, and then we have problems. So what are the symptoms? There's generally kind of irritative symptoms and obstructive symptoms. Some guys have a predominance of one type or all of them, but urgency, so going, having to know where all the bathrooms are, because if you got to go quick. Frequent urination, dribbling after urination is common. Not emptying your bladder, noting your flow is slow or weak, or you get to a point where you just can't urinate at all. That's what we want to prevent. So it's very common. Up to 95% of men have symptoms, and they're unhappy when they're dealing with BPH related symptoms. 51% of men say it interferes with every aspect of their normal life. 49% men experience sexual problems associated with their urinary symptoms. So it's a very common, prevalent disease. Affects a lot of men. Some men just deal with it, and other men seek help because it can be treated. So it's most common in men over the age of 50. As we continue to get older, the preponderance of men that are being affected by the disease continues to increase, but it does affect some men even in their 30s and 40s. And so, that's something that we see as urologists. So what do we do for diagnosis? Well, when we see a new patient that we're evaluating for prostate disease, we'll usually do a PSA test. There historically has been some controversy around that, but we vehemently support doing initial PSA testing in men that we're seeing. A digital rectal examination to get an idea of the size of the prostate, but also, are there any abnormalities as far as nodules? And then we will often do things like peak urinary flow testing and checking your bladder to see how well you're emptying, and those are non-invasive. And then we have symptom score sheets that we have patients fill out, and those validated questionnaires give us an idea how bad your symptoms are, but also allow us to monitor progress after treatment has been started. So what are the treatment options? The first line, and sometimes this is all you'll do when you walk out of a urologist's office, is be counseled regarding some behavior modifications. I see patients all the time, and they come in and they're going to the bathroom all the time, and then we find out that basically their hydration is Diet Coke or energy drinks. And so, being aware that those things can cause a lot of bladder overstimulation is very important. Also, avoiding habits where you're holding your urine too long. The classic is the truck driver that wants to make another 50 to 100 miles before he pulls over. Over time, those kind of behaviors will affect your bladder. So behavior modification is very important. The first line therapies, we'd kind of say these are the ones for the guys who aren't doing too bad, but they're not real happy with how things are going. And there's a number of medications. Another very effective and minimally invasive option is water vapor therapy. And then there's also an option of putting in implants, and these are done in the office. And then finally, there's surgical procedures, and we'll go into those in a little more detail. But you can kind of see from the left, that's not very invasive. And to the right, we get to where it's more invasive. Just a brief slide to talk about dietary supplements. There's a huge industry of prostate super pills out there. Like super beta prostate is one you hear a lot about. We have patients tell us periodically that they feel like those medicines helped them for a while, but there's not any data supporting the effectiveness of all of these alternative options or these homeopathic remedies. So, purchase them with caution. Most of them are pretty safe, but you might just be losing money on it. So watchful waiting, this is basically just saying, is this something that you have to have treated? Early on, no, it's a quality of life issue. If you're a farmer, for instance, going to the bathroom is never really inconvenient when you're out in the field. If you get an urge to go, you just go. So if that's happening every hour and a half, it's not that inconvenient for you. But if, let's say, you're somebody that's in a lot of meetings or travels a lot, that degree of symptom bother would be more of an issue for you. So watchful waiting is okay for some people, not for everybody. Alpha blockers are probably the mainstay of treatment. That's where the guy will come in and he's having some initial symptom bother and has not tried any pills. Some people prefer to avoid medication altogether, but for most patients, it's a good option, and it helps basically relax the smooth muscle in the prostate, and that lowers the resistance to urine flow. They tend to, if they're going to work, they tend to work fairly quickly. They're generally all generic now, which is nice, but they do have side effects, and some of them, can be pretty bothersome, such as a drop in blood pressure or dizziness or fainting. Another common side effect is ejaculatory dysfunction. Nasal stuffiness is not listed, but I've had a lot of patients with predisposition to sinus problems find that that can be an issue. But in general, it's often a good way to start. Another medication is the 5-alpha reductase inhibitor. So this takes a lot longer to work than the alpha blockers. But if you're a patient with a big prostate, oftentimes we may start this in conjunction with an alpha blocker. And over that 6-month period, it can reduce the size of the prostate. So, it's a good maintenance medication in men with larger prostates. And so we'll often use it that way. Side effects: erectile dysfunction. You can have some ejaculatory dysfunction with this medication, and a low incidence of breast enlargement and lowered sex drive. Resume water vapor therapy. So we're kind of moving into the minimally invasive sort of procedural options. This is an outpatient therapy that uses water vapor energy to shrink excess prostate tissue. It doesn't require anesthesia. There's nothing permanent that's put in. And through 5 years, there's about a 4.5% retreatment rate. Long-term side effects are pretty minimal with this. Early on, guys will have some potential irritative voiding symptoms where they might go more frequently, have some dysuria. You can also have decrease in your ejaculatory volume. But for the right patient, that's a determination made by your urologist and discussion with you, this may be a good option. It's very safe, and so that's attractive, and it can be done in the office without general anesthetic. So this is kind of just showing a before and after. The top picture before kind of shows in the white is the BPH nodular tissue that's starting to grow and starting to push things and compress that urethra. And by putting in the hot water vapor through a fairly short procedure, it causes that tissue to be reabsorbed by the body. So we'll just kind of play the video here and you'll be able to see that a little better. Okay, I didn't have sound on that, but
Oh, no sound. All right.
yeah, well, I think what it was showing you there, you kind of saw how the needle was coming out of the scope and right into that nodular tissue, and it injects hot vapor, and that basically kills the tissue, and then your immune system comes in during healing and basically removes that tissue, and so there's less resistance on the urethra, and that's what we're kind of seeing at the bottom of that. Most guys are very satisfied with the procedure once they have it done. Do we want to play Joe's video?
I don't know if we're going to get sound again, so maybe just move
Okay.
on.
Okay, we'll keep going. Another minimally invasive procedure that is kind of short of surgery, but a little more than medication, would be the prostatic urethral lift or the UroLift. This is a outpatient procedure that utilizes implants that are placed, during the procedure, often most of the time in the office, and it kind of pushes the prostate tissue away to create a bigger flow channel for the bladder to push the urine through. Side effects are pretty similar to that with any of these prostate procedures. General anesthesia is not required. The implant is permanent. It is non-reactive. If it's placed properly, there's not usually too much issues with it. And then the retreatment rate's higher than with the Resume, about 13.6%. And so a little bit higher retreatment rate, but can be effective for some patients. Green light laser therapy now is kind of a little bit further along the invasive scale, because this does require general anesthesia. It's still an outpatient procedure, but this is kind of the procedure that in a lot of practices has replaced the standard Roto-Rooter procedure. There's no implants. The laser energy vaporizes the tissue right on the spot, and it's pretty effective at going through a large amount of tissue, so it can be used on larger prostates. The retreatment rate's around 4.5 or 4.8% in 5 years. The side effects, again, are pretty similar. Initial painful urination, potentially initial retention, bleeding. The incontinence rates are very low, but you do get a fairly high incidence of ejaculatory dysfunction with this procedure. About 70% of men will have loss of ejaculation, not erection, not orgasm, just production of emission of an ejaculate. And let's run the video here. So, and if we don't have sound, I'm happy to do my best James Earl Jones.
Getting sound, but you guys probably aren't.
Okay, well, this is just showing the laser tip. The laser is green, and this particular laser is absorbed by hemoglobin. So the prostate being very vascular has made this almost the ideal laser for vaporizing prostate tissue. They're just kind of showing you the scope going in. The laser fiber then comes right out of the scope. So we're monitoring that fiber endoscopically, and then it just literally right in real time, instead of cutting that tissue out, it just turns it into a vapor bubble. So it's pretty effective. You know, I've been around a while and seen different iterations of laser treatment of BPH. And I was kind of not a real huge proponent of the vaporization model until they came out with their high-powered laser, which is what we use now. And it's, you know, it's just pretty amazing what it does. And so we get a removal or vaporization of a pretty large amount of tissue, which leaves you with a larger cavity through that prostate, and that helps with the bladder with regard to pushing the urine through, better flow, emptying better. And so that's a pretty important tool. And then I referenced this just a minute ago when I talked about the green light, but the TURP, or the transurethral resection, or what's been affectionately referred to as the Roto-Rooter procedure, you know, is still the gold standard. It's still very effective. There are still times where we'll do a TURP on a patient, but for the most part, you know, this has been replaced by some of the other options we've talked about. The main reason is, you know, there's a higher risk of bleeding. A larger percent of patients will have to do this and stay in the hospital on irrigation for a day, and the recovery takes a little longer because of the increased risk of bleeding. All the other outcomes, side effects, are all pretty similar to these other options. And then prostatectomy, this is done on occasion in guys with, you know, large prostates. You know, I'd say nowadays, prostates over 150 grams, you know, this is probably the most effective, consistent option. And this involves actually going in through various surgical techniques and just actually cutting out that part of the adenoma that's pushing on that urethra. You know, so guys whose prostates are 200, 250 grams, you know, this is definitely the way to go. It's more invasive, a little bit longer recovery time, longer catheter time, but very effective. It does require general anesthesia. The iTind is one of the newer things that has come out. Again, this is a temporarily implanted device that is placed in the urethra, often in the office or in a quick outpatient procedure. No general anesthesia is required. And the device is placed, it's left in place for 5 to 7 days, and then it's a very simple procedure to remove it. And during that time, this device creates a cavity through the prostatic urethra that aids with urine flow. Aquablation therapy is another one that, you know, this is kind of a mix between a surgical resection and a vaporization. It uses pressurized fluid to go in and basically destroy the tissue in real time. It doesn't coagulate as well as the vapor during the process. So after that tissue is vaporized or destroyed or desiccated, then the urologist goes back in with cautery and controls the bleeding. The retreatment rate is pretty low with this one. It does have to be done under general anesthesia. The anecdotal discussions, well, not even anecdotal in the literature, but also just talking to people that do this, there is a fairly significant number of patients that end up staying because of the bleeding afterwards. It's not the kind of bleeding you need transfusion, but it's the kind of bleeding where you need irrigation overnight. So, but it is very effective. It can treat large prostates as well. Tuna is something that not many people do anymore. I think this is the same concept as the Rezum. I think the Rezum is much more effective than the tuna ever really was. But this is where you just put in a radiofrequency needle to heat the tissue, and then the body will come in and reabsorb the dead tissue and hopefully create a cavity. I don't know of, I don't know anybody right now that still does this. Dr. Dornbier may have some colleagues that he knows, but this is not something we're offering. But historically, it was done quite a bit, and for some guys, it wasn't a bad option. But you see the 23% retreatment rate through 5 years, that's a little higher than I think is acceptable, and so it's fallen out of favor for the most part. So we learned kind of what the prostate does, and I guess I didn't expound on why we just can't take it out of everybody, but it does sit right where these erectile nerves are and the urinary sphincters are, and so the risk of incontinence and erectile dysfunction with full removal is just a little bit unacceptable. So we're kind of stuck with it unless we get cancer, but it does enlarge, and this BPH affects a large number of men. Fortunately, there's a lot of ways to treat it. We have a lot of tools now that we can use to really tailor treatment option to the patient's situation, the patient's goals, and the patient's anatomy. And there's a list of all the procedures that we've discussed. So, if you're experiencing these symptoms and they're starting to affect your quality of life, maybe you're not getting enough sleep at night because you're getting up 2 or 3 times, or you're having to alter your daily activities, or if things have gotten worse where you're having infections or having to get catheterized, come and talk to somebody, and we can almost always find a way to make it better. So I think at this point, Mike, we're going to open up for questions.
So I'm going to start with some pre-submitted ones. So first one here, we've got a gentleman who's soon to be 85. It's not had an erection for several years. He said 5. Tried some over-the-counter pills and then Viagra, but the side effects were unbearable. Then tried some more advanced ones, vacuum pump, said it was intrusive. And the question is, so are there other ways to stimulate an erection? And, things that maybe weren't discussed in this presentation. And then if somebody has tried those treatment options and failed or doesn't enjoy them, what's the next step?
Yeah, so I mean, it sounds like he's kind of run the gamut of some of the more minimally invasive options for ED treatment. At that point, you kind of look at how severe the erectile dysfunction is. We talked about injection therapies, which is usually men who have fairly severe or lack of spontaneous erections overall, as an option. But then really kind of proceeding to that penile prosthesis is always a good option for that severe erectile dysfunction, because unfortunately, outside of the things that we talked about, if you've already failed a lot of the less invasive options, then sometimes it's just best to say, you know what, let's go for a more definitive option.
Thank you. And I've got another question from a patient who's diagnosed with congestive heart failure. Said condition's been improving, but still gets winded easily, climbing up and down stairs and working in the yard. So is it potentially dangerous for them to try to have sex or engage in sexual activity?
It's tough to comment, on that type of a specific scenario. And it definitely involves probably some communication between, the urologist and other physicians who are caring for him, like his cardiologist and his primary care doctor. Um, so without, a little bit more of a look into some things, I don't think I can comment on him specifically, other than to say, having a conversation with his cardiologist about things would probably be a good option.
You. Now, there's a question about tadalafil specifically, but I think pills in general. Can you please address the interaction between medication and food, in particular the timing, and why it's important to have some separation between eating and taking that medication?
Yeah, so a lot of the PDE5 inhibitors, more specifically sildenafil, more so than tadalafil, have a decreased absorption, especially with fatty meals. Basically, the fat in a meal can wrap around some of the molecules of the sildenafil and make it so it doesn't get taken up into the bloodstream as easily. So we typically say avoid a fatty meal within an hour of taking the pill.
Are there any new ED treatments coming within the next 5 to 10 years?
Some of the ones that are getting a lot of headlines right now are things like low intensity shockwave therapy. It has approval in European guidelines for erectile dysfunction, but the United States still hasn't kind of given that seal of approval. I do think it is probably something that will definitely help men with kind of mild to moderate erectile dysfunction. We do offer it at UCI because the data has demonstrated some significant benefits for people in that categorization of erectile dysfunction. Things that are kind of coming down the pipeline that aren't well tested, and don't have quite a approval quite yet, and I don't know if they will in the future, are things like platelet-rich plasma injections or stem cell therapy for erectile dysfunction. And then there are multitude of things that are advertised and probably being tested, but they haven't really panned out quite yet.
Questions. Is there a connection between enlarged prostates and erectile dysfunction?
So there's definitely an association, and just in terms of age, in terms of when men have enlarged prostates, and as well as men who develop erectile dysfunction. The direct relationship is, I think there is a slight relationship, but there's nothing definitive in the literature. There's definitely some associated risk factors.
Looks like there's no further questions, so I'm going to put a last call up there for questions. And as we do, what is the best way if someone wants to get a hold of you or see you both to do that?
We have our contact information coming up here in a minute. Oh, there's mine. Dr. Kellerman, do you have one? Oh, either way, you can call our office or contact us at iowauro.com.
Last chance, get your questions in. Is there any daily ED treatment you recommend?
Daily tadalafil is a really good option. I often will have guys start daily tadalafil and then do what's called an on-demand boost, which is basically you take it daily, but then if you need a little extra when you want to get an erection, you can take a pill or two more.
Is a referral from a primary care provider needed to see you?
No, we will see you. It really depends. I mean, your insurance might require a referral from your primary care doctor, depending on what your insurance plan is. But for the most part, you do not have to have your primary care refer to us. You can schedule directly online or with our office as a self-referral.
It looks like we've got no more questions coming in. So at this point, Dr. Dornbier and Dr. Kellerman, I want to leave the floor open to you for any final comments you have for the people here tonight.
No, I appreciate everyone coming out, taking time out of your evening. And if you have any questions, please reach out to us.
Yeah, thank you for attending and learning a little bit more about these disease states. Don't hesitate to reach out if you want to talk about some solutions.
Thank Dr. Kellerman and Dr. Dornbier for all their time. They have busy days, so to take time out of their schedules to do this is really appreciated. And I want to thank all of you for taking a step forward in your men's health treatment journey. This concludes tonight's webinar. Good night, everyone. We'll start in the hour, but we'll give people a minute. And then we had some pre-submitted questions, so Q&A at the end. You just want to hold off till the end to do that?
Yeah.
Yeah.
We'll get started here. I'll give folks like 30 seconds to get logged in.